Welcome to the deep dive. Today, our mission is to cut through some really complex medical research and bring you straight to the insights that matter.
Hmm.
Specifically, we're looking at how artificial intelligence is tackling one of the biggest challenges in cancer care, getting survival predictions right.
And we're diving deep into a specific cancer, oral squamous cell carcinoma, or OSCC. It's, a very aggressive malignancy, making up over 90% of all oral cancers.
And it's a growing problem globally.
It is.
The survival numbers here are, well, they're pretty stark. The overall 5-year survival rate for OSCC is just around 50%, but that number, it really hides a massive gap.
A huge gap. If you're lucky enough to catch it in stage I or II, your survival chances jump to 84%.
Which is great. But
If that diagnosis is delayed, if you're looking at stages 3 or 4, the prognosis just plummets. We're talking down to only 39%.
wow, and that difference is exactly why getting an accurate risk prediction is so critical. It's not just about telling a patient their odds, right? It's about planning their entire treatment.
Yeah.
So this brings us to the core problem. For decades, doctors have used the AJCC TNM staging system. T for tumor, N for nodes.
M for metastasis, yeah, it's a standard.
It's the standard, but we know it's often not enough. It doesn't really give an individual patient their personal forecast.
Because it can't. The TNM system is generalized by design, but a real person's outcome is affected by this messy, nonlinear mix of factors.
Like what?
Well, their lifestyle,
Hmm.
tiny details you can only see in the tumor under a microscope, their overall health. All these things have a huge influence, but they're sort of ignored by that basic staging.
Okay, so that's our mission for this deep dive. We're going to unpack a study that used a deep neural network, a really cutting-edge AI, to pull in dozens of these other factors, to get beyond just TNN scores and create a truly individualized survival forecast.
This is basically a look at the future of personalized oncology.
So to solve this problem of, not having enough data, the researchers first needed a really deep and rich data set.
A massive one. And they found it. This was a retrospective look at 1,018 OSCC patients. All of them had surgery over a 20-year period at one single major hospital.
So a huge sample size.
A huge sample. And they collected an incredible amount of detail on every single person.
Okay, so let's dig into that. What exactly was this AI being fed? It clearly wasn't just the basic stage.
No, not at all. They started with the basics, demographics like age and sex. Then they added what's called the ASA classification.
What's that?
It's basically a score for how healthy the patient was overall before the cancer. And crucially, they included detailed lifestyle histories. I mean, specific records on smoking and alcohol use.
Right, things a doctor always asks about, but that don't, get punched into the final TNM survival calculator. That alone adds a lot more texture.
It really does. And then they layered on the deep pathological data, the stuff you only find out after surgery, from the microscope. This included things like the depth of invasion, or DOI, which is literally how deep the tumor has burrowed into the tissue. And it included flags for spread, like perineural and lymphovascular invasion.
So basically checking if the cancer cells are trying to escape along nerves or blood vessels.
Precisely. Those are little signals telling the AI just how aggressive this cancer really is.
What else?
They also added extranodal extension, or ENE, which is when cancer breaks out of a lymph node, the status of the resection margin.
Meaning, did they get it all out? Was the edge of the tissue clean or not?
Exactly. Negative, close, or positive. And finally, a really important one, the PET SUV max.
Okay, wait. For listeners who don't work with imaging, what is PET SUV max? It's not just the tumor size, is it?
No, and that's the key. It's a measure of metabolic activity. The SUV max standardized uptake value quantifies how much radioactive sugar the tumor is eating during the PT scan.
So a higher number means a more hyperactive, aggressive tumor.
A more aggressive, faster-growing tumor. Yeah. It gives you this physiological snapshot that the TNM staging completely ignores.
And to wrap it all up, they also told the AI what treatment each patient got. Surgery only, surgery plus radiation.
Or surgery plus chemoradiation, yeah.
Yeah.
All of that data from over 1,000 patients became the foundation to train these advanced models.
All right, so now we get to the actual bake-off. The researchers put 3 established methods up against their new deep neural network.
Right. So the traditional standard they used was the Cox proportional hazards model, the COXPH. That's been the statistical go-to for decades. And it assumes these kind of simple linear relationships.
Then you had the random survival forest, or RSF. That's a bit more modern, a step into machine learning.
It is. But the start of this show was the deep neural network, the DNN.
And what makes the DNN so different?
Well, think of it like this. Traditional stats are like trying to connect dots with a straight ruler. A DNN uses multiple hidden layers to learn all the messy, complex, and this is the crucial part, nonlinear relationships.
You mean the subtle ways that smoking history and tumor depth and peak T activity all interact with each other?
Exactly, the stuff that a simple statistical tool just can't see.
And the researchers did something really smart here. They set up a control group. They ran a separate DNN, but fed it only the TNN staging data.
Yeah, that was a brilliant move. Just to see if the old standard could be saved by a better engine.
And the result?
It completely validated their whole idea. The DNN model using only TNN staging, it was the worst performing model they tested. It got a concordance index, a C index, of just 0.504.
Whoa, hold on. Let's pause on that C index. For our listener, what does a C index of 0.504 actually mean in the real world?
It's the key metric here. A C index of 1.0 would be a perfect prediction. A C index of 0.5. That's no better than random chance.
The coin flip.
A literal coin flip. So getting a 0.504 proves pretty conclusively the TNN stage alone, even with a powerful AI, is almost useless for telling an individual their prognosis.
That's a huge finding. It just shakes the whole foundation of traditional staging. So if the TN-only model failed, which AI model came out on top?
The clear winner was the multi-classification DNN, the one that used that full, rich data set we talked about. It achieved a really superior performance. We're talking a concordance index of 0.888.
So going from 0.5 a coin flip all the way up to almost 0.9, that's a massive leap in accuracy.
Massive. And its microaverage area under the curve, or AUC, was 0.922, which is also excellent.
How did the older models do against that?
Not great. The old statistical staple, COXPH, it only got to 0.637. The random survival force was even worse at 0.557. The DNN just ran circles around them.
Now, there was a little nuance, though. I saw another model, a regression DNN, actually got a slightly higher C index of 0.905. So why did they pick the multi-classification one as the overall winner?
Yeah, that's a great question. It gets into the methodology. A regression model just gives you one single number, like an average survival score.
Okay.
The multi-classification DNN, on the other hand, was designed to break its prediction down into 60 separate monthly chunks. It doesn't just predict if you'll survive 5 years. It predicts the probability of survival at 12 months, at 24 months, at 36 months, and so on.
I see. So it generates a whole survival curve over time.
A full curve.
Yeah.
And when they checked that curve against what actually happened to the patients, it lined up much better. It was just more reliable and well-calibrated across the entire timeline, not just at one endpoint.
That makes sense. It's not just about being right at the end. It's about being right all along the way.
So now that we know this AI is actually dependable, we can sort of turn the lights back on inside the black box and ask it a question. Okay, which pieces of data did you find were the most important?
And this is where the machine starts teaching us. The aha moment.
Exactly.
So what did the AI prioritize? What was the absolute #1 predictor of survival?
The single most powerful factor, the one with the most weight in the entire model, was time to recurrence.
Time to recurrence. You know, that makes perfect intuitive sense. If the cancer comes back and comes back quickly after surgery, that points to a much more aggressive disease.
A terrible prognosis, yes.
Hmm.
But having the AI confirm it as the #1 factor, that's a really strong directive for where clinicians should be focusing their attention.
Absolutely. So what came after that? What were the other big ones?
All right, so after time to recurrence, the top factors were the worst pattern of invasion, or WPOI, then alcohol consumption history, the PE-SUV max of the tumor being older, then T staging, the resection margin, and the depth of invasion.
And smoking. Where did that land?
Smoking history was on the list, but it came in near the bottom of that top 9.
That is fascinating. The fact that in this model, alcohol consumption was statistically more significant than smoking history, that kind of goes against the grain of how we usually talk about oral cancer.
It really does. It's a critical insight. Now, it doesn't mean smoking is irrelevant. Of course not. But in this data set, the AI found that alcohol use explained more of the difference in outcomes.
So that might push doctors to, really dig into a patient's alcohol history more carefully.
Or maybe tailor follow-up more intensely for those patients. Another big validation here was PE-SUV max showing up as a top factor.
Right, because that metabolic rate is so often overlooked in OSCC compared to just the physical size of the tumor.
Exactly. The AI is confirming its high relevance. But we have to talk about the big anomaly here.
What's that?
T staging and depth of invasion were important, but N staging, the simple fact of whether cancer was in the lymph nodes or not, it did not significantly affect survival in this model.
Wait, that seems fundamentally wrong. Nodal status is taught as like the single most important factor for survival in almost every cancer. How can a model that downplays it so much be accurate?
It's a very fair question, and the authors actually address it head on. They think the problem was the data they gave the AI for end staging.
What do you mean?
It was likely just a simple category N0, N1, N2. But other research shows that what really matters isn't just if nodes are involved, but the burden of disease in the nodes.
Ah, so things like the total number of positive nodes or the ratio of positive to negative nodes, that kind of detail.
Precisely. The AI wasn't given that granular data, so it couldn't see the real signal. The problem wasn't that nodes don't matter, it's that the input was too simple.
I see. It just highlights that even the smartest AI is only as good as the data you feed it.
So we've established that this AI model can take all this complex data pathology, lifestyle, treatment, and produce a highly accurate individual prognosis.
One that just blows traditional staging out of the water. So what's the immediate real-world clinical value here?
I mean, the main application is moving from these generalized guidelines toward true precision medicine.
Yeah.
Instead of telling a patient they have, say, a generic 50% chance based on their stage.
Right.
A doctor can use this tool to give a much more nuanced, accurate risk profile, and with that confidence, they can really start to individualize treatment.
So, for example, they could use this to decide if a patient with a borderline tumor really needs aggressive chemo and radiation, or if maybe surgery alone is enough and they can avoid all that toxicity.
That's exactly it. It turns prediction into personalized planning. But we have to be critical here. As amazing as this is, the authors point out the limitations.
It was a single institution retrospective study.
Yep, so the data came from one hospital with its own specific patient population, and critically, there was no external validation.
So we need to see this model prove itself on data from other hospitals, maybe even other countries, before you could roll it out as a standard of care.
For sure.
So what's the next step? What's the next frontier for these models?
The next immediate step is to feed them even richer biological data. This model didn't have any genomics, no biomarkers, no data on specific gene mutations.
And they need to fix that end staging problem we talked about.
Absolutely. They need to incorporate detailed lymph node metrics and also things like where exactly in the mouth the tumor started, because we know that influences the prognosis too.
The power of the AI is pulling it all together, but you have to keep feeding it better and better ingredients.
And that's the big takeaway. This study confirms that AI is uniquely good at synthesizing all these messy, nonlinear relationships that define real-world cancer biology. It sets a powerful new benchmark.
It really pushes us far beyond the limits of that old TNM system.
It does.
That is a fundamental shift. So, to wrap up this deep dive, let's leave you with one final provocative thought, and it comes from the AI's strongest finding: time to recurrence. If the time it takes for a cancer to come back is the single most powerful factor for survival, how should our health systems rethink post-treatment follow-up? Should we get away from these standard fixed schedules, see everyone every 3 months, and instead use an AI profile to customize how often and how intensely we monitor each individual patient based on their actual risk? Something to mull over until our next deep dive.